welcome everybody. Really lovely to see you all. I've been running peer supports in London now for over a year, and this definitely seems to be a subject that is that keeps coming up basically as something that link workers are working on. So I thought, why not run a big session? We've got some really experienced link workers, we've got some great GPs and people working in practices, we've got service managers that are really kind of working hard on thinking about how we can develop social prescribing allies within the PCNs. Kerry, could you go to the next slide? So really there's lots of you that I feel like this is a common challenge. Lots of you are facing the same challenges. Social prescribing is pretty new to primary care still. It never ceases to amaze me the stories I still hear from link workers with GPs not really understanding their role, or even practice staff not really understanding what social prescribing is. So today we are going to hear from people who we're taking a bit of a new format for peer learning. We're going to hear from some of the more experienced link workers, a service manager, a GP, a fantastic GP who is a very, very strong advocate for social prescribing, to hear about some of the things they've tried and some of the things they think work. There's also going to be lots of opportunities for you guys to comment, ask questions, share resources. And we're going to then break out for smaller group discussion that can focus on you thinking through with a couple of other people who might be your allies. How can you develop those allies? What are some of the things you might do after today's session? Things that you've heard, inspiration you've got, perhaps things you've been planning already, but you feel now is the time to have a crack at. And then we'll come back together just to feedback and wrap up at the end, and think about what maybe we want another session like this to look like. One of the ways that we'll be engaging you as an audience is using Slido. So if you use your phone and scan that over the QR code on the top left, you should then be able to log into the event. Now, in there's going to be a couple of questions and polls that we're putting out to you guys. There's also an opportunity to pose questions. So if you're thinking of questions you either want to ask some of the presenters or you want to ask your other peers, please feel free to put your questions via your phone into the pot for discussion. You can also vote up questions that other people have put in. If you're not feeling like you've got any questions, but have a look through the questions other people have posed and vote them up if it's something you really care about or you'd like to get to the bottom of. The session's 90 minutes today, but obviously there's time evaporates when we're talking about things that are useful and important, hopefully. So we're not going to cover everything today, but it will really help us understand more about what resources we can be collating and questions we can be answering outside of today's session. It's really informal, this session. This is about peer support, really. Whilst there's content, it is really about you guys connecting with each other and talking to each other. So if you have resources that you're using, share them in the chat. If you have ideas or thoughts, chuck it in the chat. It would be really nice if all of you could change your names. So you could have, after your name, you could maybe have your role. So if you're a social prescribing link worker, SPLW, and then the borough that you're working in. And if you're a service manager, it would be great if you could put service manager and your borough next to your name as well. It will help us with the breakout rooms later. So that would be great. I'm recording the session as well because there's going to be a bit of content that's being delivered. We will be circulating the recording with slides and any resources that we are collating, referring to, and that you may generously share yourselves. The other thing to say is this is kind of new for me, this format we're trying, so bear with me slightly. Hopefully it will be great and really useful, but obviously, as always, your feedback is extremely valuable. So there will be a survey going out, a really quick survey at the end. We'll get your thoughts in the meeting, but there'll be a quick survey as well. So if you do have to leave early, it'd be lovely if you could complete that survey. Okay, next slide, please. So now we've got most of you in the role, most of you in the room. Hopefully all of you have managed to get onto Slido. That's really interesting. So we've got quite a few of you. Got some. This is really lovely. So we've got some newbies and some social prescribing elders. This is lovely. Great. Next slide, please. As you know, we're talking today about who are the potential allies in who are the potential allies. Sorry, if you go back one slide, Kerry. Who are the potential allies within your PCN? So when we think about social prescribing, you guys, I think most of you will be working with primary care networks, and a big part of your work will be to engage practice staff to let them know what social prescribing is. For many of you, that's quite a new thing. It's quite a new thing for your practices. Who are the people that are enabling you to deliver social prescribing in your primary care networks? I'm really curious to hear who you think. Have you all found it? Yes, great. I was just going to say, actually, some of you are having some network connection problems, so feel free to switch off cameras. Don't feel like you have to have cameras on. It's nice to see people, but it's also can be a bit frustrating for if your internet's not great. Some really interesting stuff coming up here. So it's funny when we think about social prescribing and we think about if you think about what's in the DES contract, there's the DES contract states that each link worker that is employed through the ARRS fund is should have a social prescribing lead within each of the practices that they work with. Obviously, your clinical director, generally speaking, would be the person that would give you your clinical supervision, and so would be heavily involved in work. I think this is really, really interesting. Practice managers coming up really big, receptionists, the people that know everybody, absolutely crucial allies. Great, thank you. If you go to the next slide, please, Kerry. We just did a bit of an outline of who the different people within the PCN might be. And actually, interestingly, the additional roles, I saw health and wellbeing coach on there. That's a really important group of people, because you guys can be referring to and from each other and being able to be, not all PCNs will have that post, but certainly it's worth being aware of them and making friends with them if you are. Conscious of time, I'm going to pass over to, we're going to hear from a few people that are working in the field right now. So I'm going to hand over to Fiona Kennedy if she's around. Fiona, are you?
Yeah, I'm here.
Great. So Fiona's I'll let you introduce yourself. Tell us about yourself.
Okay, so hello everyone. I'm Fiona. I'm a GP at Paddington Green in Westminster, and I have the title of clinical lead in social prescribing. However, I am massively benefiting from having Consia Albert, who is the social prescribing manager for all of her social prescribers. I came to social prescribing about 7-8 years ago, having previously worked in Tower Hamlets and working at the mission practice, where we had an in-house social prescriber who was awesome. I strongly believe that general practice cannot function without social prescribers, because so many of our patients don't have medical needs. They have socio-economic and other needs that cannot be met with a prescription pad or a medical certificate. So I was so grateful when I came into Westminster and the option of getting involved in social prescribing came up to jump at it, because I wanted to have social prescribing at my fingertips. And I now have Amina Begum and Najla, who is an Arabic speaking social prescriber, helping on our patch. And without them, life would be quite difficult. I think it is very hard currently. I don't think I'm doing the best of jobs getting social prescribing into central London, partially because of the pandemic. And I think that's things that we're all aware of. How do you physically promote something which is about engagement when there is no face-to-face engagement? So there, I don't say that I've got it perfect, and certainly my emails that I used to send out had about one response out of the entire network, and even then I wasn't sure that most people were getting them. So it is personal contacts that have made a bit of a difference. And certainly I would say to all of you as social prescribers, if you can and if you are able, try to go and see your practices face to face, make friends with the receptionists, get to meet the practice manager, and vitally make sure who it is, and I'm guilty of this for our social prescriber, make sure that the person who sends out the links to the MDTs each week or each month has your name down on that list to be sent out each month, so that you've already got your foot in the door, whether they like it or not. So push, and then push again. Emphasize how easy it is for people to refer to you and how it's going to impact them. So for me as a GP, I would say it's vital because it reduces reattendance. It stops having that feeling of feeling stuck with a patient. It offers a patient hope where you know there is no medical hope, and can have a real impact actually on their medical health as well, maybe reducing their diabetes, maybe reducing blood pressure. I've seen that happen in a couple of cases. So in terms of how we do it, I want to learn from you guys as well, what has worked, what hasn't worked, how I can improve. I know there's lots of areas, possibly being a less busy GP might be a start. So be pushy, get into the MDTs, and personal feedback to GPs, who then become champions and champing at the bit to promote how great you all are, because you social prescribers are amazing. We don't want you to stop doing your job, but also come and knock on our doors if you're in, email us, because it's only getting that feedback. And also if you say, I'm stuck, you're not meant to handle risk, so please call us, speak to us if you don't know what an abbreviation is. So that personal feedback to the GPs, I think, is really important. And I wanted to raise something that I don't know whether we can have a look at. If people are using an auto consult template, whether there is a way of looking at using a goal. Certainly in the one on System 1, there is a way of using a goal focus that could actually be uploaded to the homepage. So instead of searching for the social prescriber's input, there would be the goals that the social prescriber is working on the homepage of that patient's notes, so that every clinician, whether it's mental health, pharmacist, GP, nurse, whenever they look at that screen, we're all talking off the same hymn sheet, and we can reinforce those messages that you're trying to get across to the patient. I think that's me.
You know, a really quick question I had before you go is, I think there's something really interesting around social prescribing presenting itself as a solution to some of the issues. It was brought in ultimately because GPs don't have the time to spend with patients, and some of the challenges social prescribers are facing right now is being put under pressure to have much shorter conversations with their clients and being able to sort of push people through quite quickly. And I think I think one of the best ways, I mean, you can build allies, people can know who you are, but how do you develop that deeper relationship? And I wonder whether or not you could speak a little bit to how social prescribers can help GPs solve some of their more problem cases that they don't have the time to get under the skin of.
Okay, so the first thing is, I really believe that social prescribing is not just signposting. we can all send out an email, we can send out a link, but the problem is these are the patients that don't respond to this. And these are the ones where we've really got to get under the skin, as you said, Leanna. We've got to find out what makes them tick. And this is where that time and space, and I will push and write any emails necessary to say, no, you need to have that protected time, because the only way that we will be able to help these patients move forward in their journey is finding out what is important to them and working on their goal and what is important, so that then we can build something to work on in the future. And it may not be what the GP referred them for, but we need to find out why that patient feels so stuck and working on something very small and just chipping away at things. So I don't believe that you as social prescribers are just glorified help desks. I really believe that you guys are hand-holding, metaphorically, not physically, we're not allowed to, but that you are supporting someone as they move forward, and you are empowering them and improving their ability to re-engage in community. So this is not just signposting, this is far more than signposting. I think you guys are phenomenal. I would also say though that I said to one of our link workers, if you do have access to the GP notes and you see that they are on more than about 6 medications, don't have too high expectations on yourself. These patients who are on a lot of medications, it's often because they are very, very complex. And even if you were the best social prescriber in the world, I think you've got your work cut out. So I would say that the more medications, the more complex the patient appears, actually the smaller your goals should be. So it's slightly inverse to what you expect. Although they have the most need for you, they are most really the most entrenched and therefore the hardest to help. And I think you could burn yourself out if you tried to just concentrate all your energies on that one person. So the more
that's an interesting thing, isn't it? It's suggesting social prescribers to support the GP in tackling some of those trickier cases or the people they see more regularly, but also that comes with kind of knowing your own limits in terms of, you know, no one's got a magic wand. Last really quick question. I think this is another common issue. The slide I've got up at the moment about the meetings that they could and should be going along to. Sometimes it's a real challenge getting link workers invited to them. Have you got a really quick suggestion as to how link workers can elbow their way into these sorts of things? What's their route in?
So if you're in my patch, email me and I will try and get you on the email list. It is, first of all, I think it is finding out who it is who sends out the invites and making it clear that you are an important part of that multidisciplinary team. And I think that is the only way. There isn't one named person, so it may be the senior partner. And I would write a personal email that is not a blanket one to lots of different people, but send, if necessary, a series of emails where they are addressed to one person at a time and name them. So if you can get their name, and it may actually not be the senior partner, it may be the doctor that you think has a little bit more nous about them, or even a nurse or the health visitor. And it's just finding that one name that you can use to elbow or put your foot in the door. So I don't have a particular tip, as much as if you can get there in person and ask to speak to someone, don't get fobbed off, but do just keep on persevering. If you're really struggling, I'm more than happy to, even if you're outside of my patch, just promote how brilliant you are, and I will try and get you into surgeries.
Well, I am definitely going to be taking you up on that, Fiona. We need to do more engagement with GPs, and that's on the agenda for the next few months. So I'll definitely pick up with you on that. Thank you so much.
That's right. Just very, very quickly though, my big thing, and I know that Consia is also keen on this, is the fact that as GPs, we do need to understand that you social prescribers are not miracle workers. And this whole thing about the more complex the patient, actually the harder it is for social prescribing to get any hold into the patient. But we do want to potentially work with the next generation down in those complex patients. So often we may not be able to win on the patient who's already entrenched in their health-seeking behaviours, but actually the next generation down, who are the younger adults, may be more amenable, and we may be able to change their health-seeking behaviours before they become too entrenched. So trying to stop before the horse has bolted, rather than trying to shut the stable door after the horse has bolted.
I think the other thing that you'll talk, thank you so much, Fiona. We're going to hear from Chanel next. I think one of the things that you're talking about, and I often talk about it, is if you're trying to bring a wall down, you've got to find the weak point, which is the brick that you can push that's going to sort of like make the whole of the wall that you're trying to sort of get over crumble. And I think it's finding those key people, the person, and it's going to be different in every single practice or PCN, who knows all of the people who can get you on the invite lists, who is open to the idea of social prescribing and the value that it presents, and can help you brainstorm really about the kinds of people that you could and should be targeting. Thanks, Fiona. Chanel, are you around? We're massively not.
Yes, I'm here.
But hopefully this is useful conversation. So I'm going to carry on as we are. Yeah, over to you. Chanel's one of our fantastic link workers in Newham. I'll let you explain how long you've been around and what you've been up to.
Hi everyone, so I'm a social prescriber working North Newham PCN. I've been in post for about 1 year and 5 months now. Luckily I started post-COVID, so I was able to attend my practices, meet all my staff, and I was actually very fortunate I was able to give a presentation on social prescribing, because it was very new and no one really understood the role. So I kind of got that step in the door, give them a bit of an idea of what social prescribing was. But it's still been a bit of a rocky road. It's taken a while for everyone to get on board, and you might not necessarily get everyone, but as long as you kind of get those key players that can help. So for me, I would say my key players that's been really good in helping me with my role is firstly my care navigator. She's been very, very amazing. I literally couldn't get hold of her when I first started, but then when I found her in my MDT meeting, I literally just tracked her down and said, can you please stay on? I just spoke to her about the role, and she kind of really understood it. And she was really interested in the role as well. So we've been working together in partnership, because a lot of times when I get referrals, I would look at the case notes, and sometimes my care navigator would be already involved with the patient. So sometimes it'd be good just to touch base with her. And if I have any bit of questions or services and find out what has worked for this patient, it's good for me to prepare for that referral. And sometimes it's good that we're not doubling up work as well. So that's been very helpful as well. And in NDTs as well, presenting how we've been working together and what the outcomes were when I've got referrals. So if you're able to kind of touch base and create that relationship with your care navigator, I would definitely say they are very, very helpful. She's been really great. Also, I would say my clinical director has been very amazing. He's also...
Just for clarity, your care navigator is somebody that was doing similar types of work to you in the borough already prior to your arrival?
Yeah. So yes, it's very, very similar role. But I think the difference is, like you said, we kind of have a bit more time to kind of do more follow-ups, find out what matters to them. So sometimes the GP would refer them to a care navigator, but there might be other social needs. So sometimes the care navigator can say, oh, let me refer to Chanel so she can sort out X, Y, and Z, and I'll focus on that. So it's really, really good. It's been very, very helpful.
Great. And you were going to say about your CD?
Yeah, my clinical director has been really, really good, because he really understands the role, and he's very much always promoting the social prescribing when we do our huddles, MDT meetings. He's always like, yep, refer to Chanel, she can handle it. So it's always good to have him on board in getting like receptionist staff, nurses, especially when I have low referrals. I would go to him and just discuss ways on how we can get the referral uptake up, and if GPs are a bit unsure in what we can and can't do, discuss ways how we can do it. So I did like another presentation in our PCN meeting as well. So a lot of the GPs found that very helpful, because sometimes there was referring patients that were very high needs, high mental health, and it wasn't really appropriate. So it was kind of good to provide that clarity. So yeah, my CD's been very, very helpful. So if you can also have that kind of strong relationship with your clinical director, it could be any questions about clinic time, training, any questions you have, any referrals that might be really difficult, they can help with brainstorming and pointing to who are good leads, like mental health leads, safeguarding leads, who you can kind of bring those cases to as well. So they can also help kind of forge that relationship, because our safeguarding lead and mental health lead is very, very busy, but he kind of helped break that relationship as well. And just say, yeah, Chanel's had quite a lot of safeguarding cases. Can you just kind of speak to her and just give a bit of advice on kind of next steps moving forward, how she can handle those cases? So that's been very, very helpful.
You've mentioned two of my other favourite potential allies. Kerry, if you could just go back to the slide before, sorry. The safeguarding and mental health leads within, not every PCN is going to have those, or in some cases, I was thinking some people have got CDs that really don't get it and that are really busy with other things. And in the absence of having a CD that does get it, there are other people to go to, the GP partners perhaps, or your somebody like Fiona, who is a social prescribing lead within the surgery, or somebody, a GP that's got, you know, that the work that they're doing really overlaps with the stuff that you're doing. So not only will they be able to give you advice on how to shape your service, but they'll be able to support you. There'll be somebody to go to when you're struggling, or when you have a complex case, or if you're looking for some resources that can support you in your work. I was going to ask, do you have a quick tip for link workers out there that don't have a CD? What would you have done if you didn't have a CD that was on board?
If I didn't have a CD, I would literally just reach out to everyone. I was always going to the receptionist. I created like a Word document of appropriate referrals, inappropriate referrals. When I would log on once a week, I'd just send screen messages. And eventually, there's always that one person that would eventually get it. Because a few times when I'll send referrals from GPs, I'll give them a little update. And it took a while for them to actually see what I can do. And once they've gone back to visit that patient over a month or two, they're like, oh, I can actually see social prescribing working. And then they start referring more, especially when it was mainly like social needs. It might be fitness referrals or housing or both welfare and benefits, and they didn't actually know what to do. So then they started kind of believing in the role more. Sometimes it does feel a bit like you're pushing it on, but I think you have to. I literally was doing it for months and months, and there is a lot of key players. Like there's a nurse at one of my practices, she's always advocating it. So when they have their own meetings, she's always like, oh, social prescriber, and then she'll bring it to the team. So yeah, I'll just keep saying, send emails, send screen messages, talk to the receptionists, nurses. And what I do is, well, sometimes when I do welfare calls, if referrals are quite low, I might call patients that were COVID isolated, and I'll be calling those patients and I'll look at the screen notes. And if I see that they spoke to a GP a month or two ago and they mentioned that they're feeling a bit anxious as well, I can use those notes to kind of follow on when I'm introducing the social prescribing service. And that would normally make them kind of engage and say, oh, actually, I was feeling a little bit low.
Amazing, amazing. Thanks so much, Chanel. I can't see any questions coming through for you in particular. Chanel's produced some really lovely, like a lovely presentation and stuff that if you're happy for me to share, I will send out with the pack after this event. Conchia, you have an area, Conchia's a service manager in Westminster who has got apparently a notoriously tricky patch to engage. I mean, obviously, it sounds like you've got the full range of GPs. Are you around, Conchia?
I am here.
Do you want to give us a couple of the things that you've been trying out recently with your team?
Yeah, so brief introduction is I'm Conchia, Head of Social Prescribing at One Westminster. And the reason I say that is that we're based in a charity, and I think that might make a difference for social prescribers who are based in the PCN. And everything I say is tailored to Westminster, but I'm hoping that some of it's transferable for you as well. So that's my
I was actually going to say, we had one of the Marina, I'm not sure she's here today, but she actually asked specifically you know, there are a bunch of link workers. In some ways, we think that if the link worker's based in the PCN, they might be isolated, but they may also be more embedded.
Yeah.
So, you know, for those link workers that are based within a charity and sort of almost commuting into the PCN, maybe they're not necessarily part of that PCN team. Yeah, what are some of the ideas of maybe being able to engage and be seen as part of a surgery team as well as kind of a voluntary sector support?
Yeah, that's right. So I'll say the first mindset that we're going with when we speak to everyone is, we are here to make your life easier. And everyone that we speak to, that's in the back of our minds. We're here to make your life easier. And as we repeat that to ourselves, the strategies that we put in place then sort of supports that. So I'll give you a briefing of some of the things that we have done. Fiona, who spoke earlier, she is our clinical lead for the area as well. So it's great that we're both on the same call. We do what I would say, we've got sort of targeted support. The first thing we did when we started, as we started in the pandemic, was trying to contact each surgery by surgery instead of doing them by clusters. And we felt that that worked best, because what it meant is that we could find out who the sort of gatekeepers are as well as the enablers, and quickly figure out which surgeries were going to let us in to, you know, either do a presentation or just say hello. Once we managed to filter the surgeries in that order, we were then able to go in and do a bit more work. So the surgeries that were sort of relatively easy, which weren't that many, to be quite honest, there weren't that many at all at the beginning, we were able to just go in and say, this is what we do and here's the difference. Because on our patch, our care navigators are tasked specifically around focusing on medical needs, and our focus is social needs, and trying to explain to them the difference between what we do and what they do, so the value that we bring. That was our first task. And I think surgeries weren't referring to us at the beginning, because for them, why would they refer to social prescribing link workers when they have care navigators that do the exact same thing? So being able to explore that and, you know, say, you know, we're different and this is why, and this is what we bring to you, and this is how. So speaking to practice managers and saying, you know, we've got this 20-minute presentation, and if you let us do this presentation, it will give you a real good understanding of social prescribing, and maybe then you might want to refer, and it will encourage the GPs and all the other health professionals in the surgery to do the referrals too. Like I said, it was tricky, but as soon as we were able to get in, we noticed straight away the surgeries that we could do the presentations to were referring, because suddenly they understood what we did and what the value of social prescribing was. And the more they saw the impact on their patients, the more they would refer. The surgeries who were not engaging, and we still have one or two who are not, we decided the best way to deal with that was Fiona. Fiona was our secret weapon, in the sense that she's a GP herself, she speaks their language. So to say, Fiona, if you go ahead of us and you go and, you know, speak to the GPs within the surgery and say, you know, this is what we do, she would go ahead and she would do that. And once that's done, it would then enable us to come in, maybe after a few conversations, I admit, to do a presentation. And I think the presentation works because it really breaks down what social prescribing is, because I think there was sort of fear around what it does and how it was really going to work and how it fits in. And of course, and also GPs generally, sort of health staff, they don't have the time. They have so many meetings, so many pressures on their time. So we just had to reiterate to them, just add us into a meeting that you've already got existing, but we do need 20 minutes, and being clear that this is not a 5-minute update. It needs to be 20 minutes if we're really going to give you the value. Beyond that way of doing things, we attend MDTs and PCN meetings, and in both of those we give an update on the work that we've been doing. We do a presentation there, and what's nice in the PCN meetings, we can list surgery by surgery and say, this is how many referrals we have had and this is how it's worked. And you know, you can see the surgeries who haven't referred or who've only had a few referrals, they can, maybe we should think of doing a few more, because of course everyone wants to have the most. And I think it's not a sort of shaming tactic at all. It's more of a, this is the impact that social prescribing is having in the places where it's where we're getting referrals. So yeah, sending the report, spending time with the receptionist. We have felt that this is a tactic that really works. Physically going in, now that we can sometimes, and seeing people. So a lot of what we did, I'm sure with you guys as well, has been remote and just sending emails or trying to make phone calls. But now that we can go in and see them and say hello, that also makes a difference. One of our social prescribers has taken to baking. So she bakes different things and take to staff for their lunch. And I'm not advising everyone else to do that, but that has seemed to have worked and has opened doors for her in the way that she's worked. Alongside, I think the key for us is that building alliances with practices and with the key staff, figuring out who they are and in the key roles. For us, we find that pharmacists have a bit more time with patients. So the ones with a bit more time may then be able to do the referrals, but they also speak to their colleagues. It's who will speak about our role in the lunchroom or when they have their little time together. It's just that constant sort of feeding. And, you know, so it's being pushy in a sense, but in a way that's helpful and nice. So constantly going back saying, hey, we're here, how is it going? And reminding them of what we do. We've also specifically, one of the GP struggles on our patch, specifically with Fiona, is they didn't have anyone who spoke Arabic or Bengali. And our two social prescribers on the patch are one's an Arabic speaking and one's a Bengali speaking social prescriber. So we've, you know, solved a problem. And I think solving a problem for them makes a difference because they can, you know, use that for so many things. And I think something that Leanna hinted to earlier, I find helpful, which is the spreadsheet of who have I contacted, who haven't responded, and just constantly being able to follow that up so that you can always be present in the midst of those things. I think I've only been given 5 minutes to speak and I might be there by now, but I would say use your clinical leads in a positive way, stay in touch, and where you feel as if people are not engaging, just constantly go back and knock on the door and knock on a different door within that surgery. And for us, it's working and things have got better, but there is still a way to go for 2 or 3 surgeries on our patch who are, you know, reluctant, but that's the way it is. We've only been around for a year.
One of the things that I really like the sound of, I think it was Amina that was telling me that the guys were pairing up and going around the surgeries together.
Yeah.
So that's quite a nice way of doing it. So you can have a day of, if link workers have the freedom to do that, a day of just going around and introducing yourself. In the absence of being able to be there in person, what are your, do you have any tips for how link workers might let surgeries, engage with surgeries whilst they're not actually there in person? What do you think are the most effective ways of getting through?
I think a phone call is better than an email. And I say that because an email, you've only got someone's written speech and someone can sort of interpret that how they wish. But on a phone, you know, you've got voice, you can use your voice. And we found that it's better. So if you can phone, do so. And if, you know, they are not free, try and set up a time to call as well, even if it's for 10 minutes, and have a phone call.
I have to say, Helen Price, who again is in the room, and Helen, if you want to come off mute and tell us about the video, that sounds absolutely amazing. What a wonderful, innovative way to get around not being there in person. I've heard of companies interviewing now, or your application for people having to do a short video, but actually getting our link workers to video themselves to explain their service, and sending that on to people is great. I don't know if you're around, Helen. Maybe it's enough that I just...
Yeah, I'm around.
Yeah,
so one of our PC, I'm based in CVS, and we have the contract to deliver social prescribing, link worker and health and wellbeing coach services to 2 PCNs. One PCN is pretty organised in their own internal communications. The other PCN, there are a lot more internal for them issues, because it's lots of GP practices that are all getting used to being part of a PCN, because they're all individual businesses, of course. So with lockdown and with this lack of engagement by both PCNs on integrating the link worker into the system, we thought that it would be really useful if the link workers could sort of just do a talking heads, and I've put the link in the chat for anybody to access. It's on YouTube. Do a talking heads about who they were and what their aspirations were, and just to show how approachable they were. And everybody who's seen it so far loves it, and it's part of our strategy for developing relationships within the PCNs and within their constituent GP practices. And because of this work, one of our PCNs has now come up with their strategy for integrating the link workers, which, if you like, considering the link workers were recruited over a year ago, is you know, it's great that they're coming up to speed, but then that's the way it's working for us all. But yeah, so the idea is that we can share that social prescriber link worker sort of talking heads video with anybody. It's in the footer of all of our email addresses, and then in our signatures, sorry, and then there's an NCL North Central London version of the HLP social prescribing film. So then we've got that one to sort of show anybody who wants more information, and then we've got the HLP full film if we want to sort of run a session and you know, get the clinical staff that are perhaps more cynical or unsure or bothered about patient sort of safety or whatever, they can see that. I've shared with you, Leanna, as well, the comms document that we've developed and are working on with each of our PCNs, so that you can share that with the attendees here today if it's of any value to them.
Yeah, brilliant. And I think like the purpose of today's event is to really almost crowdsource some of the really helpful resources that people are coming up with. I think there's something around there's a resources page on the slides that I've created, but it's the start, and actually we want to hear from you. What do you find useful? What are you finding, you know, what documents have you found that have been great? I'm going to put in the chat the video. We're not going to have time to show it today, but the importance of link workers being part of the NDT, and you can, that's another useful thing to have on your signature if you're emailing GPs. I'm going to come, I sort of, we were definitely going to have some time for breakout chat, but I sort of want to hear from a couple more people, if that's okay. And then what we'll do is we'll cut down the feedback, and I'll just get you all to put a note in the chat as to what you're going to do when you leave this session. I think that's probably enough. But quickly, Gay, are you around? Do we have Gay in the house?
I'm here, Leanna.
Because I think you've done some great work around creating some documents for your PCNs, and also thinking about how you can really help them think through what the needs of their local community are. It feels like you've kept bringing them back to the purpose of social prescribing and used the model to really help tackle some of the issues in your local population.
So hi everyone, my name is Gay Palmer. I'm a social prescriber link worker in Southwark. Recently been appointed to the Board of Trustees for National Association for Social Prescribing. So I've only been in the job for 14 months. In South Southwark, one of the largest PCNs across the country. So we started on the 23rd of March 2020, which was the day of lockdown. And so we walked into an emergency response. So everything we had to do was very much emailing and Zoom and Microsoft Teams. Connecting with absolutely every service was done this way, which in hindsight, I'm surprised we managed to do it, but it really was quite more draining than we thought. But that was the only kind of way that we could kind of connect with our teams and with our GPs and right across the whole neighbourhood. In South Southwark, we've got 4 neighbourhoods that we kind of support, and each neighbourhood has got very, very different needs. I cover Camberwell, which is kind of the north end of South Southwark. And we noted that there's a very high Latin American community that's actually sitting within that aspect. One of our GPs, 40% of their patients are actually of the Latin American community. And one of the first things she said to me, because again, I'm very fortunate that all of my GPs very much get social prescribing. So I haven't really had to promote or push it to a degree. They've been amazing in what they do. And she kind of said to me, Gay, I need help. What can you guys do? You must have connections in the community that can best support our patients. So she kind of threw the challenge at me, and I was like, okay, let me see what I can do. I engaged with other activities that were actually going on in our local neighbourhood with the VCS and with the local authority. And it really was about connecting all the services together and how we can kind of face and tackle some of the social inequalities. And working with culture and with services, I kind of identified our Latin American communities, and we have a corporation of 12 Latin American organisations that are actually working together. Made connections with them, and as I would say, the rest is history. So with them now, we're able to say to this GP practice, this is the collective of 12 Latin American organisations who are supporting from mental health, housing, benefits, absolutely everything. So now the GP has a direct connection with the Latin American organisations that will now help to support her community. Once we're out of lockdown, I've suggested, you know, maybe once a week or however often, let them come into the surgery and actually offer the support more locally. But this is another way we've been able to work. I've worked with the local theatre, arts and theatre team who've actually done a interactive map for the Latin American community. So it's a digital interaction. So if they press on it, press on the organisation, it will show them where in London the organisation is, what the organisation can actually do, and where it is in connection to the kind of Southwark area. So again, we've hit the community in a slightly different way, making it a digital approach. And that has been with the connections with culture and with the Latin American organisations. For me, that's something really important. Again, was obviously COVID meant that we had to kind of support in terms of the COVID hesitancy. So again, we engaged with our Latin American communities and with other BAME communities and said, what are the issues? So again, culture and a lot of things were behind that scenes. And we've worked a lot during this time of doing outreach, physically going out, sending out on Twitter, using various forms of mediums. And we've been running pop-ups, pop-up vaccination clinics. And the last two, I genuinely was surprised. It's been really hard work trying to push, send emails, attend meetings, and just kind of thinking, this isn't really going to get us anywhere. But our last pop-up, we had 70 people that came for vaccinations. 60 of those were of the Latin American community who have no GPs and have no addresses. They also came, we're in South Southwark, people came from Forest Gate, people came from Willesden, people came from across London of the Latin American community to come and get their vaccinations. A lot of my clinical directors were like, what have you done and how did you do it? And I was like, I couldn't take the credit, but it's been the hard work and the pushing and the perseverance of connecting with the right people. And now it's woken up the GPs and clinical directors kind of saying, right, we need to kind of capitalize on this now that we've got their attention. What else can we do from the health perspective to kind of make their life easier? So ultimately what it's done is identified the need within that community. The community have been saying for a very long time what their issues are, but now we have got that gateway in. The health team are now saying, actually, we can see what the problem is. And now we've made a longer lasting connection. Of the BAME community, we're going to one of the churches tomorrow to do the vaccinations. And we have people that can speak Yoruba and various African languages that will also be there to participate. It's actually in a church that serves the African community. So we've really taken social prescribing to the community. Again, because lockdown means nobody can come to us. We've had to just use a different perspective and really kind of going out. What works is you have to be a little bit pushy. I have to be honest with you. You have to be a little bit bolshy and a little bit pushy. An example is one of my colleagues has been working and supporting one practice for the past 6 months. And we've been trying to engage with the practice manager, trying to get him in. And I said, you know what, let's just rock up at the door. They can't turn us away. He went in on Thursday, attended their meeting, and already since yesterday, he's had 9 referrals from this practice because we rocked up and said, hi, this is who you've been trying to connect with. He went in and I generally laughed at him saying, now you can't complain that you can't get your referrals. But sometimes it just takes being a little bit different and doing something slightly out of the norm. Many of my GPs I didn't meet till October, November, but I've been working with them since March. It's about being pushy. It's about connecting. In honesty, I get complex cases and I really sometimes wish I didn't get complex cases. However, it's kind of then connecting back with the surgeries. And this is what can sometimes make a difference in terms of how the GPs understand what's going on. So for as far as they're concerned, they've sent the referral, social prescriber will solve all the problems, and that's it. But our case studies, what we've had to do is explain, they get a discharge summary that's like 5 lines long, but they don't know the complexity of what's going on. So we've actually completed case studies of the reason for referral, which sometimes, they think it's quite easy. But then when we go into detail of the number of services that we've had to connect them with, we've had to explain the complexities of other issues that were going on with that family. And when they realize the time and the effort, the emails, the phone calls, they're kind of like, I never thought that referral was like that. So again, sometimes it's really having that chance. Again, I'm a bit of a pushy individual. I think my personality helps me in a sense. But in clinical meetings, I will actually can say, can I just kind of give you an update on a particular case? And I tend to choose the more difficult ones, just so it helps them understand the complexity of social prescribing. It's not always a very quick, simple signpost to housing or signpost to food bank or something. Sometimes it's a little bit more difficult. So again, I'll kind of go through in the clinical meetings explaining, yes, the referral that you sent, this is initially what the problem was. However, after that referral, this has also happened. I've had to connect here, I've had to connect there. So the whole team can actually hear the complexity, because sometimes I have to hear you tell them the story for them to think, actually, that really wasn't as simple as they thought. Because my presence is very much there, as I said, it was online. A couple of my GP practices, I'm now on their WhatsApp group, so I hear everything that's going on, and I feel like I know them really well. And most of them I still haven't physically met. So it's 50% of the team I haven't physically met, but I felt that during the lockdown, via the WhatsApp, the MDT meetings via Microsoft Teams and Zoom, I've got to know them really well. So it's been, and now I can kind of say, hi, they're going for coffee. Next time I'm in, I'm like, that's great. So it really is sometimes just about being, persistent. And then also, sometimes you're going to say, yeah, it doesn't always work, or they kind of turn us away. After a while, they do start to respond because they're seeing the impact. Some of my GPs, it's because of the patients that have gone back and said, no, actually what Gay did was really helpful. This is what they've helped to do. So sometimes the very word and feedback from the patients themselves also helps the GP. So now one of my GPs, as soon as they mention this, Gay, I'm immediately referring to you, because they're hearing the impact another way.
I love the idea of you elbowing your way into WhatsApp groups, as if we need any more WhatsApp groups. But I feel like that definitely is, if there was a WhatsApp group to elbow your way into, that's definitely the one.
It works. It does work.
It's amazing. I want to try and squeeze in Justina. If we can, her reception's not great right now. Actually, no, she's texting me to say that she keeps getting kicked out of Zoom. One of the things I really wanted to mention is the use of EMIS. Thank you, Gay. The use of EMIS and how we can use some of the reports in EMIS around either identifying particular patient groups or being able to go back to your surgeries in your practice meetings and say how many people you've helped and what the impact has been. Perhaps that's for a slightly different session, or maybe we can create a, it's possible we can create a cheat sheet around that. I think Justina's coming back in now. I think let's go to some breakout rooms, because I think what would be really good, Kerry, if you could just move on to the slide explaining what we're going to be doing in the breakout rooms. So essentially we have, I think there are such amazing ideas coming out today, and I've just seen Jacqueline's idea about about assertiveness training. What an amazing idea. I think that's something I'm definitely going to follow up outside of this meeting, as well as sort of collating all of these brilliant ideas. What we're going to do is go into breakout rooms now to have a little bit of a discussion around who you think your allies are, what do you think, who would you like to become a better ally, what might the challenges to them becoming an ally be for you, but what ideas have you got to turn them around? And ultimately, I think it would be nice when we come back in, I'll bring you back in 20 minutes. if you all have 1 or 2 things that you want to put in the chat that you are going to do when you leave today's session. So have a discussion with each other. You're in quite small groups, 2 or 3 of you, and yeah, have a I think what we want to get towards is what are you going to take away from today's session, and what will you do? Okay, I'm going to pop you all into your rooms. Hopefully you will, I'll cut and paste these questions as well and put them in the chat so that you can see them all. So we've got everybody back in. We've got most of you. So we've got about 26 people in the session. 9 of you have done this. Maybe not everybody's managed to get onto Slido, but that's interesting. Still quite a lot of you working from home. I think that's going to have a massive impact on your ability to engage. Hopefully some nice ideas have come out of today.
Leanna, if the people who are managing are the largest proportion of the 9 that have responded, then that's going to skew the figures at the moment, because I'm working from home all the time, but my team some of them are out and about. So
that's a very good point. I should have said, shouldn't I? Only link workers reply to that.
I'm sorry. Yeah. So yeah.
No, that's my fault. I'm not being very clear. To be honest, I've got a head cold, and I cannot promise that I am thinking the straightest. But thank you. That is a very good point to raise. That actually, I think 4 of us. I think 4 of us on the call. The group just now, out of the 5, were in the home environment, not the work environment. So it may be if we've all responded. Yeah, and actually, you're right. It's I would say anecdotally, people are starting to go back into surgeries, even if it's just to say hi. And I think that is, if for anybody that's nervous about doing that, you're in good company. And actually, maybe some of the issues are surgeries don't have space right now, and that's another thing to consider. We're trying to encourage surgeries to increase number of link workers, build capacity, get health and care coordinators and health and wellbeing coaches and care coordinators in post, but where is everyone going to sit at a time where everyone's still socially distancing? So there are challenges to this. If we could go, so one of the things I was going to ask, actually, if we go to the next slide, Kerry, and I'm just curious to know how useful you guys have found today's event, so I'll let you answer this question. If you could also, in the chat, I'm really curious to know, anybody that's got something they are going to leave today's event with, something they've got in mind they're going to do. I'd love to hear about it in the chat. There's a feedback form that's gone out to you all that is goes into a bit more detail. It's also asking you about sort of how you found I'm interested in it's a slightly different format today, a mix of some presentation and some chat. I'm interested to know what other subjects you think would fit this format. We have a session planned which will be on motivational interviewing at the end of next month. That's going to be more of a training session, very practical training session. The month after that, we were thinking we would tackle outcome measures, because it feels like it's something that's coming up in peer supports a lot. How can we best use them? What other ways we should be employing them? I think there's a bit of an overlap there with talking about impact, some of the stuff we've been discussing today. So yeah, it's any ideas any of you have got, basically, in terms of what the themes for future sessions like this that can be pan-London, and we can bring everybody together with a few really good best practice examples, hear from some people that are in the audience, as well as maybe have an opportunity to discuss some of the stuff that we've heard in smaller groups. Then my door is open. Please let me know your ideas. Kerry, could you go to the resources slide? Just to finish up. So next steps, I'll click the recording, I'll send it out with the slides. There's been tons of really great ideas. So many of you have sent in some ideas. We've had some ideas from some clinicians as well around how to develop social prescribing allies within your PCN. We'll pull this all together into a pack and get that out to you next week. It will be a working document. Any ideas people have got that they want to add to it, then let me know. It will be loaded up onto the future NHS collaboration platform. Not everybody is signed up to it. We're hoping that we will also soon have a platform to host some of these materials for social prescribing in London. Send anything you've got that you want, that you think is relevant to this, to me as well, and I'll include it in the pack. Any last comments from anybody before we wrap up and close? Yeah, Helen.
I put it in the chat. Has everybody seen the new competency framework document that we've launched? It came out on Monday, I think, on the 24th from NHS, the NHS Social Prescribing Link Worker Competency document. But then there's also the Health and Wellbeing and Care Coordinator welcome packs have been launched this week or recently. I think it was you, Leanna, who shared that information actually. But anyway, they're really worth looking at because they're bringing things right up to speed.
A really good shout, I think. So the other thing to say, actually, whilst I've got you all here, I'm sure the fact that you're here is because you are getting my newsletter, but the newsletter will be going out next week, and the competency framework that NHS England have developed will be in that newsletter. It's quite a long consultancy period, so they are looking for feedback up until I think it's the middle, the 16th, 17th of July. They're looking for comments on that for. There's also, I think the other thing to mention, which is kind of related to what we're discussing today, a letter went out in January about mental health roles going into PCNs, which are part funded by the local mental health trusts. These are going to be really, so you've got your personalised care roles that you might connect with the care coordinators and the health and wellbeing coaches, as Helen's just mentioned. Those mental health professionals that are coming into your PCN, it's not predetermined what kind of a mental health professional they may be, but it could be that they could be an incredibly good ally of yours. I'm doing a bit of research as to how they're being used across London at the moment. In a couple of months' time, we'll have a bit more of an idea. So hopefully we'll have an update for you on that as to who some of those people are and examples of how they're working with social prescribing link workers. So watch this space. Anyway, it was lovely to see you all today. Please do fill in your feedback forms. Anybody that wants to stick around for a quick chat at the end, please feel free to I'll hang around for another 10 minutes.
Yeah, can I just say one more thing, which I think is feedback to the people on this call, and that is, I'm just accepting that as a yes, and that is that as social prescribing link workers, remember that you're the specialist. You are the specialist in that work. So just because a clinician or an admin person doesn't understand what you do doesn't mean that you have to back down. You know, you are the specialist. There's a huge amount of training, and be proud of that and stand up and say, but I'm the specialist, you know, I want to help you with my specialism. I think that's really important. Certainly in our area, it's been sort of, you know, have the power to say that.
In fact, I wish I'd led with that. Why didn't I lead with that? Right, Helen's going to be chairing the next meeting.
No, she's not. You did a great job despite your cold. And
expect Helen. No. I want more of this, and I think the whole point. You know, my role is not going to be around past. Potentially might not be around, you know, it's not going to be funded by NHS England past next March. I mean, you do need to start thinking about how we can sort of bring this to the system. Do we think that there's value in a London network? And if so, how can we keep it? How can it be self-sustaining? And how can it be, you know, how can we create some structures so that it's actually kind of easy to carry this on?
How do we campaign for your role to remain at least until 2024, which is the intense period of that NHS wants to recruit, you know, all these 9,000 link workers?
Well, it might be, it might, if we think that there's a need for it, my approach would be to then campaign to the ICSs to all put in a bit of money to make sure that there is this post and it's really clear what's happening at a London level versus what's happening at an ICS level versus what's happening at a borough level or a PCN level. Because I think at the moment there's lots of duplication, and it's really, we've got to be really careful not to either tread on each other's toes or be inefficient, I suppose, in the way we're working.
Keep raising the Belbin model of form, storm, norm, perform. It's like you can't make that happen any faster than it can happen. And what's happening in the NHS is there's so much change and so much new stuff that you've got all this forming, storming, norming. And when are we going to perform? Well, we can only perform when we've gone through those processes. And I think that's really important to remember, you know, and it makes some people's jobs really difficult if we can't acknowledge that there's going to be a period of we don't call it failure in Enfield, we just call it learning from what didn't work or what went wrong or what we did badly or whatever, because that's the way we're going to eventually perform. But
yeah, I agree, I totally agree. Actually, on that point, Helen, we're trying to organise a map for we're trying to create a kind of a bit of a picture of what's happening in social prescribing in the various different pockets across London, and you guys are doing some amazing stuff. It'd be really lovely to feature your service on that map if possible. Would you mind if could we book in half an hour to run through some of the questions with you? That'd be all right.
Yeah.
Great. Anybody else? Any more? Speak up.
Have a good weekend.
Yeah, and a lovely bank holiday. There's going to be some sunshine, 22 degrees in London apparently, and then half term next week. So I hope everybody's got, you know, some time booked off. I actually said to one of the breakout rooms earlier, if one of the outcomes from today, if the thing that you put in the chat you will do is go and take a holiday or a break, because I think sometimes that gets in the way of our ability to sort of our patience and our ability to develop positive relations or have resilience in the face of people that are determined to be ignorant or misunderstand. Sometimes a holiday can do the world of good.